Good morning. Chris from my friend's attic in Western New York in the Chautauqua Institution. Hope everybody's doing well today. Good morning, Johanna. Good to see you. Always here. Thank you so much, girls. Good to see you. I hope you're doing well. We are one lecture away from being done with this semester. Can you believe it, Johanna? It's been a long semester. You've done a great job, but we are now finally done here with Psychology 150. And of course, we got Dimitro in the house. Good morning, Dimitro. Next to last lecture, folks. You have done a great job focusing this semester, doing all of your schoolwork and being good students, and it is now time to be rewarded for that with a grade in this class. And I'm glad to see you folks here today. So we're going to talk a little bit about go ahead and get started. Chapter 15 talks about a lot of things. The first thing it talks about is who exactly seeks therapy. Now, you'd be surprised how many people do not go seek therapeutic treatment for the psychological disorders that are bothering them. Many people have disorders that they suffer with for their entire life because they don't want to go to a psychologist. You know what? Crazy thing. My mom, God bless her, had anxiety disorders her whole life. My mom, wonderful, brilliant person, but she could have used some psychotherapy. But my mom told me, oh, okay, right, I'm sorry. I keep forgetting that I can't switch to that inset. And so my mom always used to tell me that psychologists were quacks and she was never going to go to a psychologist. Can you imagine your mom saying that to you when that's your life's work? That was her. A lot of people don't go for the disorders that they need treatment for, but who exactly does go? So you know what? You don't even have to have a discernible treatment necessarily to be in treatment, right? So sometimes people seek treatment for anxiety problems that aren't clinical. They may have difficulty selecting between new jobs. Counselors work with people who don't necessarily have a psychological disorder but are having a challenging situation that they need help figuring out. So you don't even have to have a clinical disorder to go talk to somebody. And I highly encourage each and every one of you at some point in your life to use the professional services of one of these counselors or psychologists. You know what? I'm not ashamed to admit I've been to counselors before, and personal counseling and marriage counseling. I think it's a great thing. It's always good to talk about things with someone who has a different perspective than you. The most common psychological disorders people seek treatment for is anxiety and depression. Okay, now, and that's typically because when people have anxiety or depression, it makes them feel bad. They have personal distress. Remember a couple of days ago, I talked to you about the 3 broad criteria of psychological disorders. Is it distressing? Is it maladaptive? And is it seen as weird and odd by other people? Most of the time, people with anxiety or depression feel badly and suffer because of their condition and are aware of it, and also know that it's making them unproductive at work. So these are sort of the common conditions that people are actually going to seek treatment for. Now, the thing is, it turns out that if you look at this chart underneath me, it shows you some of the patterns of those people who go for treatment. you're going to notice that females are much more likely to go talk to somebody than are males. Caucasians are much more likely to talk to somebody than are Black or Hispanic patients. People with a lot of education, college educated people, are way more likely to seek treatment than people who do not have college education. And people who are not married are more likely to seek treatment than people who are married. And then, of course, people with insurance are more likely to go see a doctor than are people without without medical insurance. So cultural factors may determine, for guys, we're supposed to be tough and stick it out. You don't have a problem. You just need to toughen up. And so you're going to see males less likely to get treatment than are the females. There are cultural beliefs that different ethnic groups have about the stigma associated with searching for psychological treatment. And that may explain why we have ethnic differences in attendance rates at therapy, right? And you'll see the one thing I kind of like to point out is people who are married, the research is going to suggest, and I'm not trying to be conventional, I'm not trying to push you, and I don't care if you live in sin or decide to be single your whole life, but the research suggests that marriage tends to convey some happiness and some value to people. And so what you're going to see is that married people are less likely to seek treatment because they have less problems, maybe, because they have somebody to talk to, probably. But there are definitely variations in who seeks treatment for their problems. Hey, good morning, Matt. Good to see you. Thanks for coming. Next to last day of class, dude. I am so sad that I'm going to miss you folks when you're leaving, but it's good to see you here anyhow. Okay, if you remember, we talked a little bit, or actually, I don't know if I did talk about this. There are different kinds of treatment professionals out there. So we have clinical psychologists, psychiatrists, counseling psychologists, clinical social workers, psychiatric nurses, and counselors and marriage and family therapists, right? So a couple of quick things about this slide that I want you to know. The most common psychiatric professionals are probably going to be your psychiatrist and your clinical psychologist. These are the people that treat these serious psychological disorders: schizophrenics, bipolars, depression, anxiety, body image disorders. If so, you're going to go see either probably a clinical psychologist or a psychiatrist. Both of them have terminal degrees. That is, your clinical psychologist is going to have a PhD, and your psychiatrist is going to be a medical doctor, an MD. Both of these people are doctors, if you will. Now, the difference between the psychiatrist and the clinical psychologist being that the psychiatrist is a medical doctor, they are trained in the physiology of drug action. So they understand the physiology of the body much more than a clinical psychologist does. And so a psychiatrist is the one that is allowed to diagnose and give you psychotropic medications. So if you've ever been given an antidepressant or an anti-anxiety drug, I promise you that even though you may have only talked to the clinical psychologist, somewhere in there is a psychiatrist that rubber stamped the okay for your medication. So psychiatrists and clinical psychologists are going to treat the most severe problems, and a lot of times you're going to see them in hospital and clinic settings. Now, counseling psychologists, you'll notice that we have counseling psychologists. They're similar to clinical psychologists. They have a PhD. They may have a PhD as well, or an EDD, but they focus on adjustment problems, people having difficulty at work, having difficulty at home, or having difficulty in their career. Still a PhD, maybe. They can be a master's too, but they focus on adjustment problems. So not a psychological disorder, but difficulty at work, difficulty at home, difficulty at school. All right. Now, your book talks about, oh, actually, I should probably be talking about it on this chart. So if you look right here, so clinical psychologists, counseling psychologists specialize in the diagnosis and treatment of psychological disorders. Both require a doctoral degree, like I said, a PhD, a PsyD, or an EDD. Honestly, I don't know a lot about EDDs treating psychological disorders, but I have heard of PhDs and PsyDs. And those are two graduate programs that can lead to a practice in clinical psychology, right? And so these are the psychologists to engage. So and your psychologist, as opposed to your counseling psychologist, are more likely to have a PhD, and they're more likely to be a research expert as well than a counseling psychologist. We're differentiating these from psychiatrists. The psychiatrists are uniquely different from clinical psychologists. They go to med school. They don't go to grad school. They go to med school. But one of the rotations that they do in med school is one for psychiatric disorder treatment. So some medical doctors will do a pediatric rotation. Some doctors may do a cardiology rotation if they want to become a cardiologist. Some may do an OBGYN to become an OBGYN specialist. But some medical doctors are going to do the psychiatric rotation, and they're going to specialize in treating psychological disorders. So clinical psychologists and psychiatrists both treat the most severe disorders that people have. However, the psychiatrist is a medical doctor and can prescribe medication. The counseling psychologist, like I said, they're going to treat less significant disorders. They're not going to treat psychological disorders as much as they're going to focus on adjustment problems, difficulty in different environments that we find ourselves. Now, those are the main psychological professionals: clinical psychologists, counselors, and psychiatrists. However, there are also other mental health professionals that you may run into. Now, I know some of you are probably interested in nursing degrees. You may be trying to pursue your BSN, your Bachelor of Nursing, or maybe you're just wanting to get your RN degree. Did you know that there are some nurses that are also co-trained along with their nursing stuff? They're also trained in the identification and treatment of psychological disorders. And so a psychiatric nurse is a nurse that helps people suffering from psychological disorders that find themselves in a hospital for some reason or another. So they're going to be the person that helps you while you're having difficulty in the hospital. So your psychiatric nurses. And then we're going to have some psychiatric social workers, which are people that work in social work environments. You know, in social work environments, they try to help people, groups of people, with different resources. So they fight poverty, you might fight hunger, you might fight people. I have an uncle who has an MSW degree, and he provides counseling to AIDS patients. He used to do a lot more of this in the 80s and 90s before the treatment got so good, and these AIDS patients needed more treatment because they were having acceptance and sickness issues. And so a psychiatric social worker is going to be a social worker who works with populations of people, and they actually, not only do they know stuff about psychological disorders, but they are also trained social workers that can help the person get the resources from the community and environment that they need. And so these psychiatric social workers are going to have, usually they're going to have like a MSW degree with some sort of specialization. And these psychiatric social workers are going to be social workers, but they also have the ability to treat people in these settings who are suffering from psychological disorders as well. Seems like we have a couple more people on the line besides Matt, Dimitro, and Johanna, whoever you are, even though you haven't typed in the chat bar. Thanks for coming today. It's great to see you. Okay. Now, where do you find therapeutic service? You're going to find psychologists in in several different settings. You're going to find some of them in private practice. You can go through the back of the phone book. I guess we don't use the phone book anymore, but you can find people who have private practices, just like dentists and optometrists can have private practices. So can therapists. And in fact, the two therapists that I used in my lifespan, both were private practitioners that were recommended to me. They had their own little office. They're basically small entrepreneurs, small business people. How did the term shrink come to be associated with psychology? I think that's a pejorative term. I don't know if you've ever heard of in Africa, they have those shrunken heads, those witch doctors that shrink heads. Psychologists have always been thought of sort of as witch doctors, if you will. And a lot of this comes down to the fact that we don't have medical procedures and biological things that we can point to. And what psychologists do sometimes don't make sense to people. We have weird techniques, behavioral techniques that we use. We're changing the way people think. And so I think what they do is they stole this term from witch doctors who had shrunken heads, and they say that like witch doctors, psychologists shrink people's heads. So I'm a shrink. Does that make sense, Paul? Nobody's ever asked me that question. That's a very good question, Paul. Hilarious. Okay, so you'll find them in private practice. You'll also, there is absolutely, I would agree. Paul's right. There is still a huge stigma about mental health issues, even in Western societies as well, I would say, Paul, but even more so in non-Western societies. And I don't know if you had logged in right when I started, but one of the things that I mentioned was my own mom told me that psychologists were witch doctors and she would never see a psychologist, and she totally rejected the whole field. I'm like, Mom, this is what your son does. I'm a psychologist. She's like, I know, but I just don't believe in the whole field. And so my mom needed treatment her whole life, but refused to go because she had no faith in the process. And I'm sitting here going, Mom, and so it was funny, this maternal rejection, professional rejection that I've had through my whole life. So you're right, there is definitely a huge stigma. In fact, I even tell people that I've been to therapy, individual therapy and marriage counseling as well. Now, it's a little embarrassing for me to say this because I don't want you to think that I'm weak. And that's the stigma that Paul mentions working right now. But the reason I always mention this to my students is because I want you to feel good enough about going to a psychologist that if you need some help, you will go get some help. There is absolutely no problem with talking to somebody if you need a little bit of perspective. And Paul's is right. We tend to have these really negative ideas about psychologists and people who go see psychologists. Could you imagine if you broke your arm and society had a stigma about having a broken arm like they do about having schizophrenia? People make strong judgments about schizophrenics and don't want to be around them. Could you imagine if they treated you like that if you had a broken arm or if you had high blood sugar, right? If you had diabetes. Now, along with private practice, you're going to find clinical psychologists and psychiatrists in community and mental health centers and in hospitals. You're going to find them. You're going to find your clinical psychologists and your psychiatrists mostly in community health centers and hospitals. You will probably hardly ever find a psychiatrist in private practice. You'll find a few clinical psychologists in private practice, but most of your clinical psychologists and psychiatrists are going to be found in centers, larger psychiatric type centers, treatment type centers. All right. Now, you're going to find your psychiatric social workers in human service agencies, and you're going to find counselors in schools and workplaces. All right. Now, so you're going to find them all of these settings. There are a few people in private practitioners, but as the notes say over here, you're going to find most of your therapists in places other than in private practice, community health centers, hospitals, agencies, and schools. All right. Now, does it matter if you have a male or a female therapist? Research has not found any link to suggest that it matters that you see a male or a female. So if you're a female, you might say, do I need to have a female therapist? Not necessarily. If you're a male, you may say, do I need to have a male therapist? Not necessarily. Instead, it depends upon what you need, what you are comfortable with. I remember my wife and I actually tried two therapists. The first therapist was an older male therapist who had sort of a Christian bent to his therapy, and it just didn't work. We went 3 or 4 times, and neither one of us felt comfortable with this therapist, and we just couldn't talk, and we absolutely had no progress under this therapist. So we then switched and found a marital therapist who just turned out, we didn't pick on purpose, but she was a younger female, and we hit it off with her and were able to talk with her and work through our issues with her. And so for us, it wasn't necessarily that we used a male or a female. What we had to do is we had to find a fit. And it is okay if you go to a clinical psychologist and do not like them and do not feel like they are the person for you. It is okay to change. The most important part of therapists is not whether or not they're male or female, but whether or not you feel good enough talking to them. Because most of your therapy is going to be talk therapy, working through your problems, dealing with issues, conversations with this therapist. So if you don't feel a connection with them, if you don't feel like you can talk to them, then your therapeutic process is not going to be successful, no matter how well educated they are and how fancy the therapeutic place you are at. It's all about feeling comfortable with your therapist. Now, is therapy always expensive? You know, it can be, but it doesn't have to be. And your book gives 2 suggestions. If you're lucky enough to have insurance like me, what you're going to find is more and more insurance companies are finally paying for psychiatric care. And so what I would suggest to you is if you think you need to talk to somebody, but you're afraid to do it because you don't want to spend the money, go check your insurance. You would be surprised how cooperative insurance companies have come towards helping people treat psychological disorders. If you remember, this hasn't always been the case. Again, it's this idea of not having organic things that we can put our finger on, which is why health insurance companies have always been a little leery of psychologists. You're depressed, really? That's not something I can quantify, and insurance companies don't like things that they can't quantify. However, I would tell you that the culture has shifted in the last 20 or 25 years to a point that now most good insurance companies are going to provide you some sort of benefit to help you if you want to seek treatment. Now, if you don't have insurance and you can't afford to pay $250 to a private practitioner, and yes, that's what they charge, you can go to a community health center. Maybe you're not going to feel quite as grand about that, but there are public intake centers where you can get help for nothing or next to nothing. And so there are different places that you can go for treatment. The therapist that I did use, that my wife and I did use, their going rate was about $250 an hour, but we filled out the insurance paperwork. We'd have to pay our small deductible, I forget, $20-25, and then the insurance company would handle the rest of it. So treatment can be expensive. Treatment can be, sometimes there's a lot of meetings in between the beginning of treatment and the end of treatment. It can get expensive, but there are ways to minimize the costs associated with the treatment of these therapies. Okay, now, how many different types of therapies are there? There are really kind of sort of three therapeutic traditions to treat psychological disorders. And these psychotherapies involve a helping relationship between a professional, that is the therapist, and a person in the need of help, which is the client. So therapy, a psychotherapy, is a relationship and a set of behaviors, procedures, or drugs that you and your practitioner come to agree upon that will help you achieve relief from whatever it is that are bothering you. Three main categories of therapy. Insight therapy, which is sort of like where we talk and I help you come to insights about your life, figure things out about your life. Okay. Wow, I didn't realize I have these unresolved feelings of hostility towards my mom or my dad or to whatever. I didn't realize that abuse that I had as a child really affected me. Insight therapies are therapies where you go in and talk to a person and try to come to some realizations that maybe were hidden from you. That's one type of therapy. A second type of psychotherapy is behavioral therapies, where we use things like punishment and reinforcement and conditioning to affect our psychologically distressed behaviors. So one of the things you might do is you might come in and tell me you have a bad temper. And you and I, what I'll do, or let's say, actually, here's a great behavioral therapy for people who are trying to quit smoking. It's an aversive therapy technique. It's a behavioral therapy technique. What they tell you to do is you get a big rubber band and put it around your wrist, right? And so let's say you're going to quit smoking today. You put that band around your wrist. Every time you think about having a cigarette, you take that band and pull it out and snap it against your wrist, and it will hurt. And what you're doing is you're punishing yourself for every thoughtful desire to have a cigarette. And the idea is by punishing the impulse to have a cigarette, you can change the smoking behavior. This is sort of a behavioral therapy. And then what we're going to talk about tomorrow is we're going to talk about biomedical therapies. That is drug therapy, psychosurgery, electroconvulsive therapy, and other therapies that try to change people based upon changing the biological substrate that exists up here. Now, insight therapies and behavior therapies are sometimes called talk therapy because I'm not doing surgery on you, I'm not giving you a drug. Instead, the therapy is nothing but talking. It's about, the focus is talking between a professional and a non-professional. And so there are three main categories of therapy. Now, if you look at this chart over here, what they're going to suggest to you is that there is this rising use of medications in the world of psychological treatments. So you'll notice that moving from 1998 to 2007, those people using psychotherapy or just behavioral therapy has gone down. All right. Now, the best approach is to give a person insight therapy and medication, the biomedical therapy, both of these therapies together. And you'll notice that that's sort of the orangish line here, and the use of giving psychotherapy and medicines at the same time is actually going down. What is increasing is the treatment of psychological disorders using nothing but medicines, drug pills by themselves. It's become much more popular in the last 20 years. Do you want to know why? Because it's cheaper. Because it's cheaper. That's why. Your insurance company does not want to pay the $225 that you need to go see a therapist. Instead, they'd rather pay $1.50 a day for the pill that will help you get better. Now, and I think this is a crying shame because I think that we don't know enough about the biological mechanisms of mental illness to really have truly effective medicines. And I think the best approach, in fact, what in the field, if you talk, most people will agree that the best therapy is going to be an eclectic blend. That is, in the blend of one of these talking therapies, either one or two, along with three. But as you can see right here, the trend in modern psychology, and it's all money related. It's all, I don't mean to sound like a paranoid conspiracy theorist, but it's all because the insurance companies don't want to spend the $250 a week for the treatment with the psychiatrist or the psychologist, when they can spend $20 and give you some sort of medication that is supposed to help you. Any questions so far? I haven't seen a lot of questions in the chat bar. I hope that means that I'm describing this so perfectly it makes sense. I hope it doesn't mean you're bored, but who knows? We'll see. All right, now, insight therapies. And you'll see the picture right here. This is sort of the classic stereotype of the clinical psychologist sitting in a chair, and you'll notice the patient is in sort of this laid-back couch talking to this psychotherapist. This is a great picture that demonstrates insight therapies. And insight therapy is talk therapy. That's really what it is. You and your therapist are going to talk, and you're going to try to come to some sort of insight about yourself, some sort of self-knowledge, and hopefully this will allow you to make healthy changes to your personality and your behavior. Now, insight therapy was actually invented by a fellow named Sigmund Freud. We haven't talked too much about Sigmund Freud. Paul, I think you actually liked the Freudian lecture that I gave the first week of class when I talked about blocks and people hiding things from themselves, and defensive behavior, and the id, the ego, and the superego. I remember, Paul, you actually really liked that chapter. You know what? Insight therapy, Sigmund Freud sort of coined this. And basically what he did was he thought that most people's problems came from unconscious things they weren't aware of. Maybe you're ashamed or embarrassed or angry about something, and you are not really aware of it. You're unwilling to deal with it. So maybe your mom and dad treated you poorly as a kid, and you have some hostility towards your parents, but you've learned how to hide that hostility. And what happens is that hostility comes out in different ways and affects your relationships with other adult people. You might come into my office as the insight psychologist, and after 2 or 3 sessions, we might realize that your hostility is not because people are making you mad, but it's because of something that happened to you years and years ago that you still haven't dealt with. This is sort of the form of insight therapy that was created, made important by Sigmund Freud. And Freud's brand of insight therapy was called psychoanalysis. Now, you really won't find psychoanalysis therapists anymore. And I don't have time to tell you why Freud's theory is flawed enough that it is not used. But you won't find a true psychoanalysis person that talks about sexual instincts or the Oedipal complex or penis anxiety or castration, penis envy or castration anxiety. Those are all weird Freudian terms that are used in psychoanalytic approaches. You don't really, there are some psychoanalysts out there, but you won't see very many of them. Instead, what we have now is a more broader approach called the psychodynamic approach. And we know that people suffer from blocks because they are embarrassed to admit things, or they don't have the ability to admit things. Either it makes them sad, it makes them angry, or whatnot. And so the idea is to help these people work through these problems. Your book's going to talk about 2 classic traditions in insight therapy. Each focuses on an important area which represented in modern psychotherapy. Now, I'm not going to tell you all about psychoanalysis because psychoanalysis in its original form isn't used anymore. I'm not going to talk about Carl Rogers and client-centered therapy in great detail because there are some drawbacks and some limitations of the client-centered therapeutic approach. What exists now I don't recall liking the Freud lecture. I've always preferred Jung. Okay, well, I just remember I was talking about some Freudian concepts, and at the end of lecture, you said, wow, this really makes sense and is interesting. Maybe you didn't know I was telling you about Freud, Paul. Who knows? Okay, now, so what I want you to know is that even though modern psychotherapy can't really said to be either client-centered or psychoanalytic, instead, modern therapy sort of uses a blend of both of these traditions. Now, what do we take from psychoanalysis? The idea that a lot of times people are not aware of the things that are bothering them, and that it is going to be a process in making you aware of the things that are bothering you. Okay? Okay? Now, the second approach is client-centered therapy. And what client-centered therapy focused on that we believe is very useful is building a good relationship between the client and the therapist. You know, in psychoanalysis, Freud was sometimes combative with his patients. He thought his patients weren't aware of certain things that were affecting them. And so it was Freud's job to disagree with these people and sometimes to make them cry and unhappy so that they could realize these things. So Freud wasn't always necessarily in an alliance with his therapeutic patients. On the other hand, the client-centered therapist thought that nothing was more important. And whereas Freud might make you angry, the client-centered therapist's goal was never to make you angry, and instead to make you feel like you had a friend that you could count on. Okay? So what I'm going to do is I'm going to talk a little bit about the concepts that are drawn from these in the modern therapeutic approach. So I'm talking about modern therapy, but it used some client-centered therapy concepts, and it used some psychoanalytic therapy concepts. So, Freud believed that most people are unaware of the emotional conflicts that cause them psychological problems. That's what I suggested to you that we're borrowing from Freud. And so he argued that the first step in the therapeutic process was helping this person uncover those hidden things. Once they become unhidden and they become obvious to you, they then lose their power, according to Sigmund Freud. Now, if you look at these definitions over here, these are some Freudian terms that were identified by Freud, and the blue terms represent how they're used in a modern setting. So when you went into a Freudian analysis way back in the day, Freud wouldn't say anything. Freud would just sit there and look. He wouldn't ask you any questions. In fact, you could even go to a Freudian therapy session, and if you chose not to say anything, Freud wouldn't say anything. Could you imagine spending an hour just sitting there with your therapist, not saying a single thing? That's what Freud would do. It was a very non-directive technique. And what he would do is he would wait for you to say something, because according to Freud, even though you weren't aware of it, your problems would always bubble to the surface. And so you might say something like, I talked to my dad today. And Freud would say, really? How does that make you feel? And then you would start talking about your feelings, and Freud would uncover some sort of negative feeling. So whatever it was you chose to talk about, if you said, you know what, I had a sandwich today, Freud would explore that. He would allow you to express exactly what was on your mind, because he thought the problems always bubble to the surface. And then he would drag that out of you and make you realize that it was an emotional sticking point to you. Now, here's the deal. Most modern therapeutic encounters aren't quite as undirected as Freudian therapy is. So if you go into a modern therapist, they're not going to just let you sit for an entire hour. Instead, though, they are going to have you talk about what you think is important. All right? So when you come in to my setting, I would say, all right, so what do you want to talk about today? And you would start talking, and then we would handle those problems. Freud, on the other hand, wouldn't do that. He would just sit there. There's this, I forget the guy's name, Charles Murray, I think it was, a famous psychotherapist, went to visit Sigmund Freud, and he took a long train trip. It took him many hours. he got to Freud's office. They sat down, and he said, boy, whew, I tell you, Freud, I had this terrible trip. There was this kid on the train that was annoying to me. And Freud looked and said, was that little kid you? And so Freud took what this guy said that was completely random and tried to use it as a point of therapeutic treatment. We don't do that. Instead, though, the therapist will ask you to tell me what's on your mind. What do you want to talk about today? Now, Freud would engage in interpretation. He argued that people live their lives symbolically. And the things that we do symbolically represent these unconscious conflicts that exist in our mind. And so Freud would have you talk about the things that occurred to you, and then he would find the symbolism in these, and he would interpret your behavior. So he would interpret your, explain your motives and the inner significance of what was going on in your mind. Freud would do that. And sometimes it would be conflictual because people wouldn't believe his interpretation. But Freud insisted that you have to believe my interpretation because he was the therapist. That's where the conflict came in. Now, what would he interpret? One of the main things that he would interpret would be your dreams. If you'd go dream at night, come back and tell Freud your dream, he would tell you how your dream related to your psychological problems. Now, in modern psychotherapy, there is some interpretation, but the therapist never makes the interpretation. Instead, I ask you to tell me what you think your feelings and your behaviors mean. The modern psychotherapist would never provide you an interpretation of your behavior. In fact, my experience has always been when you ask a direct question to the therapist, like, do I have a problem here? The therapist will usually turn it around and say, well, I don't know. Do you think you have a problem? You're like, damn it, I want an answer. And the modern therapists won't do that. They'll make you sort of interpret your own behavior. Now, they may guide you, but they're never going to interpret your behavior. They know that you have to come to an interpretation about what your behavior means. And so if anything's interpreted in modern psychotherapy, we let the client do it. And if a client wants to try to figure out what their dreams mean, your therapist may encourage you to do that, but they're not going to do it for you. So there is interpretation in modern therapy, just like in Freudian therapy, but it's done by the patient and not the therapist. Now, Freud often believed that people were unwilling to give up their neuroses. It is difficult for people to change. People are resistant to change. Now, Freud thought that people engaged in these really bizarro, petty sort of tricks to avoid telling him their problems. They might forget their appointments. They might come late to their appointment. They may have any reason for why they avoid talking to Freud. Freud would call that resistant. You're being resistant. Now, we don't necessarily talk about that in modern psychology. Your psychologist is not going to try to figure out why you didn't come to therapy today. If you cancel an appointment, your therapist isn't going to say, oh, you're being resistant to the treatment. However, modern therapists do know that a lot of times people have difficulty truly confronting the things that bother them. So there is a little bit of resistance. Now, Freud used to think that in order for you to get better, he would have to become the person that you were having difficulty with. So if you're having difficulty with your spouse, let's say I'm married and I have difficulty with my female spouse, what Freud would expect was that at some point during our therapeutic process, I would take my anger that I normally expressed against my wife, and that emotion would be transferred to Freud, and I would yell at Freud and get my emotions out that I had on my wife towards Freud. And he called this transference. And Freud, since his theory was primarily sexual in nature, he expected that all of his patients would at some point develop sexual attraction and sexual feelings for Freud. And he argued that what they were doing is they were transferring these sexual feelings from another target to him as a part of the therapeutic process. We don't talk about that in modern therapy anymore. However, we don't say that you're becoming a model. You're becoming the proxy mother, the proxy father, the proxy wife, or whatever in the therapeutic process. But what we do know is that therapeutic process and the events in therapeutic process do involve strong emotions, which may involve the therapist. So it's very important that a therapist learn how to be a little bit independent from the situation that's going on. You will never be able to talk to a therapist who has a friendship with you. If you're friends with a therapist and you say, hey, I need some help, they're probably going to try to direct you to somebody that you don't know. And the idea is they want to try to keep these emotions, these strong emotions, from clouding the therapeutic process. So your therapist is going to be your ally, but they're never going to be your best buddy, because we know that there's a lot of emotion that comes out in therapy. And so it's very important for the therapist to be neutral as possible. So these are all terms that were sort of coined by Freud. These are concepts identified by Freud that were a part of his psychoanalytic process back in 1900. They've evolved, but we still use these terms in a therapeutic process. So we talk about what the patient wants to talk about, which is like free association. Now there is interpretation, just like in Freudian time, except we encourage the patient to interpret their own behaviors and motives rather than us telling them what their own behaviors and emotions are. And we know that therapy is a difficult process that is sometimes difficult for people to talk about the things that really, really bother them. Okay? Now, what are your client-centered therapy techniques that you're going to see? Client-centered therapy, as created by this fellow named Carl Rogers, was an insight therapy that emphasizes the need to provide a supportive emotional climate for clients who play a major role in determining the pace and direction of their therapy. Now, I talked about this a little bit earlier this semester. You may remember it, you may not remember it. I talked about the authentic self and the ideal self, and the need for congruence. People need to be accepted for who they are. If they don't feel feelings of acceptance, people change their identity to gain that acceptance. The only problem is their real identity stays the same. And so what happens is a person starts showing this face to the world when they're really this face. And it's the incongruence between these two identities which causes psychological problems, according to Carl Rogers. So for Carl Rogers' therapeutic process, what he needed to do was he needed to bring you into the laboratory, into the lab, the clinic, and for a few minutes a day, he would make you feel genuinely accepted for everything that you felt, everything that you thought, everything that you believed. Instead of judging you, this person would accept your feelings on face value and be willing to talk about them. What the therapist was doing in Rogerian therapy was trying to build a therapeutic alliance. That is a relationship, a partnership between the therapist and the client. Now, whereas Freud might be your combating enemy trying to make you feel things that you didn't want to feel, the Rogerian therapist would never, ever do that. Instead, trying to give you a sense of what we call unconditional positive regard. The therapist is going to remain supportive and non-judgmental about anything you think or feel. If you think this way, if you feel this way, then it's legitimate. Who am I to judge the legitimacy of your feelings? And so a therapist, a Rogerian therapist, would provide this unconditional positive regard. They would be honest with you. Whereas Freud would never tell you what he was feeling or thinking, a Rogerian therapist might tell you when something you said bothered them, or they might tell you when they were feeling uncomfortable, or they might share with you their own things that are going on. This honesty helps build a therapeutic reliance. And then the therapist, not only because they give unconditional positive regard, they have a great degree of empathy. The idea is that the therapist is supposed to understand it from your point of view. How do you feel? Now, being genuine to you and sharing myself, accepting everything you said as being your point of view in a real emotion that you experience, what I'm doing is I'm creating a therapeutic alliance that allows us both to work together. With this approach, the client and therapist become friends, almost equals, if you will. With Freud would be sitting up, you'd be laying down. Freud was in charge. In a Rogerian therapist, we are both in charge. Hey, take care, Matt. I'm sorry, time's out. It's good to see you and I hope to see you tomorrow night. And the therapist asks you to clarify what things mean to you. And so the whole point of client-centered and psychoanalytic theory complex, this all boils into a modern approach where you come in and we're going to talk about what you want to talk about. I'm going to accept you. I'm going to validate your points of view and allow you to feel okay about having them. I'm going to understand that there are things you're not aware of that are difficult that we need to talk about. And I'm going to help you try to become comfortable enough to talk about these things so that you can achieve enlightenment or the insight that insight therapy processes. I am out of time. There's a difference between, we've been talking about individual therapy. There are some people who believe that group therapy is important because it's important to see that other people are suffering the same difficulties as you. Makes you feel a little bit more normal about having them. You can see how people deal with the therapist, and you can learn while other people are getting therapy as well as when you get therapy. So I want you to read about group therapy, and I want you to read about the effectiveness of insight therapies, and what they in the factors that make insight therapies useful. I am so sorry for running out of time today. 10:52. I appreciate all of you for staying here, and I appreciate it. Y'all have a great day. Paul, Dimitro, and whoever here's online, thanks for coming today. Y'all have a great day, and I will see you tomorrow morning at 10 a.m.